So, thank you so much for joining us for NAMI Maryland's 40th Annual Conference. My name is Monique Owens, and I am a volunteer for NAMI Maryland. I will be your moderator for this session today. This workshop session is Cognitive and Behavioral Issues in Later Life, presented by Michael Friedman from Columbia University School of Social Work. You can read more about our amazing presenters, including their full bios, in the digital conference program on the official conference website. Professor Friedman will provide an overview of demographic and epidemiological data regarding cognitive and behavioral health issues in late life. He will note unmet needs and suggest a long-term agenda for advocacy to meet the challenges of the rapid increase in the population of older adults now taking place. If this is not the workshop you want to attend, please click the back button on your browser or click on the sessions button on the left-hand side of your screen to return to the full list of workshops we have available. We will be addressing questions at the end of this presentation. If you have any questions as the presentation continues, please post them in the Q&A on the right-hand side of your screen. We will be reviewing questions as they come in, and if something in particular is unclear or needs to be expanded, we will ask the presenter after their presentation has concluded. We are pleased to offer closed caption for this year's conference. Captioning is only available to attendees using a desktop. To enable captioning, please click the CC icon below the display of our presenters at the bottom of your screen. Once you click the icon, the video display will become smaller and you will see the captions being generated underneath. If you have any comments, concerns, or technical issues, please post them in our chat and our technical assistant will address them accordingly. I'd like to take the moment to welcome our presenter for today's workshop, Dr. Michael Friedman. Thank you so much for joining us today, Dr. Friedman.
Well, thank you for the introduction and the opportunity to speak with everyone today. Let me begin by saying that I can't see any of you. I understand that you can see me, and I can't see the chat. So I won't know what questions or comments you're posting until the end of this session, unless I get interrupted along the way. I'm going to do a very rapid overview of a lot of material in this presentation. It's a kind of an experimental approach, and I apologize for experimenting with you. But hopefully this will work well, and you'll let me know at the end if it does or it doesn't. The basic fact is that we are in the midst of an elder boom. That is to say, the population of older adults is growing very rapidly. I'll give more information about that. And that is not, when it comes to cognitive and behavioral health, it's not an issue of much concern in the world today. There's much more concern about the viability of Social Security, the viability of Medicare, and so on and so forth. That's really unfortunate because people who are older do develop all sorts of mental conditions, including dementia, mental illness, substance use problems, problems that their families have. There are service shortages, limited access to services, uneven quality of care, limited integration, limited quality, continuity of care. We'll talk about all of this as we go along. Because of the failure to meet the needs that are out there, there's not only avoidable individual and family suffering, but also premature death and disability, excessive institutionalization, and very high healthcare costs. In order to deal with these issues, it is necessary to have significant growth of current services to keep pace with population growth, but we're already have too few services and we have inadequate services. So in addition to keeping pace with the growth of the population, we need to take, as I say here, bold steps to improve services to overcome the service shortfalls. As I said, I'm going to move very rapidly through this presentation, so I thought I would begin with the end. Summary. I've sort of given it already, but here it is on one page. The population of older adults is growing. That means that the population of older adults with mental conditions is growing. There's a lot of unmet need now. America and Maryland are not prepared to meet the need, and therefore we need an action plan now that includes making sure that people can live where they prefer to live, usually in the community, making sure that families get the support that they need to help their family members who have mental challenges to remain in the community. We need to address the shortage of capacity, access, quality, and equity. We need to promote psychological well-being, which, as I will note as I go along, is quite possible for older people. And there needs to be adequate funding to do all of this. So let me move rapidly through this information. Over the next 40 years in the United States, the population of older adults, I'm using 65 generally as older, population of older adults 65 and above will increase from 16% to 23% of the overall population and outnumber the proportion of children. That's an astounding change in the makeup of the American society. In Maryland, it will not be quite as extreme, so that by 2045, we expect there still to be more children than older adults, but the growth will have been very substantial, from 16% to 21%, and there will be a decline nationally and in Maryland of the population of working age adults. That's of considerable concern because will there be enough working age adults to support the society and to provide the help that children and older adults need? The number of older adults in the United States will will almost double over the next 40 years. And in Maryland, just in the next decade, there'll be a growth of 320,000 additional people, older people in Maryland. The fastest growth among older people is of people 85 and older. They will almost triple over the next 40 years in the United States, and in the next quarter century in Maryland, they will increase by over 150%. From 122,000 to 315,000, from 2% to 5% of the total population. These are very significant shifts in the population of the United States and of Maryland. There will also be a substantial growth, as we know, of people of color in the United States. Rather soon, the number of people of color will exceed the number of whites in the United States in general. And in fact, already in the population under 18, the population of children and adolescents who are people of color is greater than the number of whites. But with older adults, the picture is somewhat different because the population change and the population mix is depending, to put it crudely, on the death of white people, so that as over time there will be more and more people of color, a much larger proportion of people of color. But the change in the United States over the next 40 years, we expect right now it's about 80% of the older population is white. That'll drop to about 55%, and in Maryland, about 2/3 of the older population is white now. That'll drop to about 50%. One of the interesting facts to me is that the Maryland data merge the Asian population in with the other population. Hopefully the planning department will break that out the next time that they do this. Important to know that, as you probably all do know, that the number of men and number of women, those proportions shift in older ages, and there are more and more women and fewer males. By 85, there are almost 2 women for each man in the United States. That's a very significant fact in understanding what the life of older women is like. 46% of veterans are over the age of 65 in the United States, 42% in Maryland, 165,000 people. We usually, when we think about veterans these days, we think about veterans of Afghanistan and Iraq, so that they are the younger veterans. But the veterans of Vietnam are people who are older. And there are still some survivors, even from the era of World War II. There are a host of cognitive and behavioral health conditions. By cognitive, I'm referring to a mix of dementia, of which Alzheimer's is the most often referred to and most common, and what's called mild cognitive impairment, which is really not so mild. And I'll get to that in a minute. So cognitive is a term that I'm using to refer to the dementias and mild cognitive impairment. Behavioral health refers to both mental illnesses and to substance use disorders. So here's a partial list of the kinds of conditions that we're concerned about: dementia, mild cognitive impairment, severe and persistent mental illness such as schizophrenia, late life psychotic conditions, severe anxiety and depression, mild or moderate anxiety and depression. Substance use, often overlooked in conversations about older people, but there are some very substantial issues here which we'll talk about. Autism and other developmental disabilities. It used to be that people with developmental disabilities didn't live to be old. Now their life expectancy is getting close to the life expectancy of people without developmental disabilities. There are people who have lingering cognitive and psychological effects of illnesses and injuries. COVID has had a significant impact. Traumatic brain injury has a significant impact. There are a number of neurodegenerative disorders that have psychiatric symptoms that are commonly associated with them. Very important to know that many anyway, of people who have mental conditions have co-occurring disorders. So there are cognitive impairments such as dementia that co-occur with behavioral health disorders more later. Behavioral health disorders co-occur with physical health conditions. Mental disorders co-occur with substance use disorders and vice versa. Developmental disabilities co-occur with dementia or behavioral health disorders. And many of these neurodegenerative disorders, such as ALS, co-occur with also behavioral health disorders. We're going to talk some about the co-occurring disorders, which are really important to understand in all of this. In addition, there are people who may not have diagnosable mental disorders of one kind or another, but who do suffer substantial emotional distress in reaction to the life experiences that they have. The pandemic, of course, has increased emotional distress, but there are other factors that happen generally in society and that are just traumas in people's lives that have a significant effect on their emotional condition, even if they don't result in diagnosable disorders. And then as we age, we face certain kinds of psychological challenges, and we'll talk some more about that later on. Cognitive and behavioral disorders are quite prevalent. These are estimates for people 50 and above. What you'll find if you look at the epidemiological literature is that it's all over the place, and some is for 50, 55, 60, 65, 70. So we've got some mix in here. And I have chosen to use the Alzheimer's Association's numbers for dementia. They put it at about 11% of the population, actually over 65. This is the 14% is the National Institute of Mental Health estimate of the numbers of people 55 and above with any kind of mental illness, diagnosable mental illness, and roughly 4 to 5% of older adults have substance use disorders, but many more have substance use problems that don't constitute disorders. Moving to the cognitive disorders, there are, as you probably know, several different types of dementia, of which Alzheimer's disease is the most common. I'm not going to go through the detail on this. I mentioned mild cognitive impairment. This is a stage between the expected cognitive decline of normal aging and the more serious decline of dementia. So it's a little difficult to know exactly at what point a person is moving beyond having the normal memory problems of aging. And this category exists to try to capture that. Very important to know that people who do have or would be diagnosed with mild cognitive impairment have considerably increased risk of later developing dementia. Some people will recover from this, but many people go on to develop dementia. Dementia increases with age, no surprise there. This is a finding from recent research which I think is dramatically important and suggests to me that there ought to be a reconceptualization of the division that currently exists between thinking about cognitive disorders or dementia and thinking about the mental illnesses. They are generally separated into different silos. I'll say more about that later. And they really shouldn't be. This finding is really, as I say, very important. People who have dementia, 98% of the people who have dementia will at some point during the time that they have dementia also have what are called co-occurring neuropsychiatric symptoms, which is a fancy way of saying they're going to be anxious, they're going to be depressed, they're going to develop psychotic conditions, they're going to have behaviors which are very, very difficult for them to deal with and for the caregivers to deal with. So this is a very important finding that needs to be kept in mind. Jumping now to the behavioral health disorders. There are various types of behavioral health disorders, as I've already said: anxiety, depression and mood disorders, psychoses, substance misuse, and other addictions. Now, I do want to dwell for just a minute on alcohol overuse and dependence. There's a difference between the two, and there are many older adults who overuse alcohol without becoming technically dependent on it. Alcohol probably is the most serious or common of the substance use problems that there are among older adults. The other major one is the misuse of medications. Some of that is taking too much medication. So, for example, many people who are older suffer from chronic pain and end up taking too much pain medication, which does contribute in some people to opioid addiction. But other people take too little medication, in part because they can't afford it. There's relatively little misuse of illegal substances, and when one thinks about substance use disorders among older adults, you need to be thinking more about alcohol and medication than about heroin, cocaine, and so forth. That exists, and it is a problem. I don't want to understate that. But the way in which substance misuse shows itself in older adults is more with alcohol and medication than with the illegal substances. Gambling is, of course, also a significant problem among older adults. For mental health disorders, the CDC estimates 20%. I earlier used a number 14%. That's the NIMH number. One of the interesting things about doing the work that I do in looking at the epidemiological research is how the numbers vary from study to study. So you should always think of these numbers as approximations. It's important, I think, to say that 80%, if CDC is right, 85% if NIMH is right, of older adults don't have a diagnosable mental health disorder, because it's quite common to think of older adults, particularly to think of older adults as having depression. And I'll comment about that later as well. But the fact of the matter is, most older adults are doing pretty well. 20% is a big number, however. That's a lot of people who have mental health conditions, mental illnesses, who are older. Over the course of a lifetime, about 50% of us will have had a behavioral health. So again, that's quite a substantial number. Anxiety and depression are highly prevalent here. Again, if we look at the numbers, interesting. The prevalence of anxiety disorders is about 11.4%. That, by the way, is lower than the prevalence of anxiety disorders among younger adults, but not by much. People generally think about depression when they think about older adults. I happen to think that that reflects ageism in our society. If you're old, you must be depressed. But the prevalence of major depressive disorder, as you can see here, is under 6%, and that's less than the prevalence of depression among younger adults. But there's also what are called here self-reported depression symptoms, and that, of course, is a much higher number. Important to keep in mind in these conversations and in what you read, sometimes what you're reading about or talking about are symptoms of depression. For example, all of the studies that are being done about the psychological impact of the pandemic are talking about symptoms of depression. They're not talking about diagnosed major depressive disorder. So those are different. So these are the numbers. We're talking about a variety of different kinds of disorders. When we talk about the mood and anxiety disorders, look at it quickly. Not going to dwell on that today. What's more important from my point of view is to understand how serious the consequences can be of having anxiety or depression, which sometimes sound like, what's the big deal? Well, big deal. There's much increased risk of dementia in people who have anxiety and or depressive disorders. There is some thought out there now that, in fact, anxiety and depression and schizophrenia may be the early phases of what later becomes dementia. Interesting thinking going on about that. But in any event, people who have anxiety disorders or depressive disorders are considerably more likely to develop dementia. That's a big deal. There's an increased risk of disability and premature death for people who have mental illness. There are high rates of suicide, problems in relationships, which of course are very significant. Both anxiety and depression feed loneliness and they feed isolation. So if isolation and loneliness cause depression, which they do, they are also caused by depression. Important to understand the vicious cycle that takes place here. They contribute to reduced productivity, reduced engagement, and high rates of substance use. There's a lot of co-occurrence of anxiety, depression, and substance use problems. And it's important to know for those who are trying to work on what's known as nursing home reform, which basically means let's use nursing homes less than we do now, that there are much higher rates of nursing home admissions for those who have anxiety and depressive disorders, either with or without a dementia, but much higher than with dementia alone. Suicide is very disturbing. Generally speaking, suicide increases with age. That has changed in the last decade. I'll talk about that in a minute. But if you look at this graph, what you'll see is that it's sort of going up, except it's higher here at 50 to 64. But the highest rate, and it's look how high it is in comparison to all the other rates, is for 85 and over men who are 85 and older. So in the United States, it's approaching 50 per 100,000, right, compared to an average suicide rate in the country of 14 per 100,000. That's an astounding difference. In Maryland, the picture is just about the same, a little bit different. Now, what's happening here? In the past decade or so, there's a phenomenon that's emerged in the United States, which is referred to as deaths of despair. There have been some look taken at why the life expectancy in the United States was declining before the pandemic. Before the pandemic, life expectancy was declining in the United States. And it appears that that was happening because of increased death rates of working age men particularly. So that, and part of that was, as I say, deaths of despair, which means suicide, drug overdoses, and alcohol-related deaths. So what we've been seeing in the United States is a phenomenon of working age men with no more than a high school education apparently just losing hope of ever achieving anything like the American dream. And the speculation is that there's a rise in suicide because of that. But suicide also continues to rise with age, particularly among men. Important to know, if we're talking about suicide, that the most common way in which people take their own lives is with guns. In Maryland, for all ages, 40% of suicides involve the use of guns, but for older adults, 60%. In the nation, it's 50% used guns at all ages and 70% of older adults. So the issue of access to guns is a very important issue when we're looking at the mental health of older adults. As I noted before, people with anxiety and depression are at high risk for dementia. They are also people, particularly with severe mental illness, at risk for more serious physical disorders and premature disability and death. That relates to high rates of smoking, obesity, diabetes, and heart disease. Have to wonder whether antipsychotic medications contribute to obesity. High rates of substance abuse, the lingering effects of homelessness and criminal and victimization, poor access to physical health care, behaviors and lifestyles that increase health risk, high suicide rates, as I've talked about before. So for people with serious mental illness, which is of course the population that has been of major concern to NAMI over the years, there are some very significant challenges as people age. The increased risk of chronic health conditions and of dementias, previous slide. Institutionalization, because there's not housing or other services in the community that can address people who have severe mental illness and co-occurring physical or cognitive disorders. The long-term care system, where people are moved, older people are moved when they have these co-occurring disorders, are generally inadequate when it comes to care and treatment of people with serious mental illness. And one of the things that I think is very serious and not taken seriously enough, and that is people get moved from place to place. So a person who may be well settled in a residential program or in independent living in the community with some supports, and when they get older, they can't get enough health care, And therefore somebody says, well, okay, we'd better move them into long-term care. Well, you know, when people get moved from one place to another, there are a lot of personal relationships that get left behind. And I'm afraid that our system thinks about these transitions more as if they're movements from one level of care to another than thinks about them as what they are, transitions, disruptions of personal relationships that people have developed. As people with serious mental illness who continue to need care from family caregivers age, it becomes increasingly likely that their family members, their family caregivers will suffer from disability or they will die. And dealing with that is one of the big issues, I think, for people with serious mental illness as they age. I mentioned that alcohol, medications, illegal substances are an important problem. They also have serious consequences. And there are some of the numbers that are here. I mentioned before that the major problem, as I see it, is the misuse of alcohol, not necessarily addiction. Here, we've put in the number 14.5%. I've seen studies 15 to 20% of older adults consume more alcohol than is recommended by health authorities. And that comes with high risks of falls and other accidents, as well as physical illnesses. So that the use of alcohol is something that needs considerable attention among older adults. Although there is some use of illegal drugs, most of it is the use of cannabis, which interestingly enough is becoming no longer an illegal drug. So the misuse of heroin, cocaine, methamphetamine is limited among older adults. Important problem, of course, but limited. The misuse of prescription opioids, which has been highly publicized for older age groups, and which does sometimes lead on to heroin use, is a significant problem among older adults as well as among younger adults. And in general, the misuse of prescription medications can result in injury, addiction, or death. So these are serious problems. Just one example, the rate of overdose deaths is going up among older adults. I mentioned earlier that people with developmental disabilities are now surviving into old age. There's a whole piece of work that needs to be done now to understand much more about the lives of people with autism and other developmental disabilities who are living to have more of a to have the lifespan, the life expectancy of the general population. I mentioned earlier that people suffer from emotional reactions to adverse life circumstances, and make up your own list. I'm sure you can all do this. Grief, fear of death, loneliness, economic distress. I've got a whole long list here. Happy to send these slides out, by the way, if anybody wants them. Now, as people age, they move into another developmental stage. What age that happens at differs from person to person. This is quite a subjective process, but retirement and other role changes have a significant impact in the lives of people who now need to find other sources of meaning, as well as other sources of income and contact with other people. In general, the older you get, the fewer social connections you're going to have, which contributes to increased social isolation. And we need to develop new relationships, and that includes intimate relationships, sexual relationships, which is something I think is under considered in talking about the needs of older adults. Dealing with loss and grief becomes much more common with age, And there can be as many ads on television as you like that tell you if you only use this skin cream, you won't have wrinkles. And if you only take whatever it is that comes from jellyfish that will make your brain better, then you won't have the losses of physical and mental functions that are almost inevitable in old age. Uh, Important discussion to have about that. People learn to live with people like me. I'm almost 80 now. We learn to live with these declines. Um, some of us become dependent. That's a tough thing for people, and learning how to tolerate that if it becomes necessary is an important change in old age. And looking back, um, as I sometimes say, quoting Robert Frost, it's important to be able to look back with pride. Almost nobody, I think, can look back with total pride about their past. We need to come to terms with who we've been and feel that we've had lives that are adequate, if not lives of greatness. And of course, we're all going to die. I've already mentioned that co-occurring disorders have a very significant impact. Premature disability and death, I'll probably say that over and over again, high costs of care. Now, it is, I think, very important to say, as I tried to say earlier, that most older adults actually do pretty well in old age. There's a distinction drawn in the literature between objective successful aging and subjective successful aging, and the studies that have been done about objective successful aging say, well, most older adults are not objectively doing as well as they might. And the reason for that is that chronic health conditions are so common. And with that, some disabilities that develop typically in old age. But when you ask people, how you doing? The vast majority of them say, I'm doing okay. That's subjective successful aging. And what contributes to that is a positive attitude, optimism, adaptability. These are certain personality traits that some people are lucky enough to have and some people are not. But the key elements of it are having satisfying relationships with people and engaging in activities that provide pleasure or meaning. And there are a whole host of those. Grandparenting for some, volunteering or working for pay for others, civic and political activity for many older people, engagement in creative arts, which is quite significant in the lives of many people, and various efforts at self-improvement. And, you know, a lot of people take up golf when they get older. And for some of the people who take up golf, it becomes a real challenge to play golf as well as they can. And these are things that contribute to well-being in old age. Having a sense of self-worth, taking care of yourself, and so forth. These are all things that contribute to doing well in old age. I do a whole presentation about this, which I'd be delighted to do at another time. There's a lot to be said here, but the important point to take away here is that as we think about the needs of older people, the mental needs of older people, there are things that can be done to promote well-being in old age, and that should be on the agenda. I mentioned that depression is less common among older adults than younger adults, and I mentioned in saying that I think that the reason that we associate depression with old age is ageism. Younger people, tend to think that getting old really is dreadful. And of course, who wouldn't be depressed if you're going to get old? As I just said, the vast majority of older people actually subjectively are satisfied with their lives. And so when we talk about depression, which is real and important among older people, but we need to also understand that it affects some people, not nearly all. There are certain high-risk populations People with serious mental illness, who I've talked about, people with cognitive impairments are high risk for behavioral disorders. I've already talked about this. Very importantly, older Black and Latino adults are at higher risk for dementia and have much more limited access to behavioral health services. Given the importance of trying to address the disparities that exist between people of color and white people in the United States, these are very important findings and target some of what we need to address to be able to increase equity in the United States. Poverty is associated with increased risk of all of these things, and look at the disparities related to poverty. 10% of older adults live in poverty. That's a vast improvement since the war on poverty was started in the Johnson administration. But look at the variation: 7% for whites, 20% for Blacks. That's a huge, huge disparity. Women also at higher risk for cognitive and behavioral disorders. They're much higher risk for social isolation because men die much younger than women. And as I said, by the age of 85, there's only one man for every woman, for every two women. And they are also, for whatever reason, at higher risk of dementia, perhaps because they live longer. They're at higher risk of anxiety and depression. Interestingly enough, they're less likely to have substance use disorders. They're also more likely to attempt suicide, but far less likely to complete suicide. But there are special issues for women that need to be addressed. For the LGBTQ plus population, there are also significant challenges. It is interesting to me that this is the population next to the population of people with disabilities that have had the hardest reaction, emotionally speaking, psychologically speaking, to the pandemic. Residents in nursing homes and assisted living facilities are also at high risk. Well, obvious, right? Why would they be in a nursing home or assisted living if they did not have these kinds of issues? These problems are much more common, particularly the behavioral health commons are much more common than is generally realized. Veterans, I think we all understand, are at very high risk for complicated co-occurring physical, cognitive, and behavioral disorders, including PTSD, including high rates of substance use disorders, and including high rates of suicide. Loneliness and social isolation increase the risks, and the findings about that recently have really been quite striking. The summary of that is that some researchers are saying that loneliness and social isolation are more dangerous to your health than smoking. And it's a substantial issue. About a quarter of older adults are socially isolated. About a third are lonely. I see I have a typo here, so I'll have to fix that. But the social isolation is an objective state where you don't have much contact with people. Loneliness, you can have contact with people and still feel lonely. People who experience trauma are also at high risk, and they have very limited access to trauma-informed care. And the numbers on this are quite significant. They vary from study to study. In this study, which I believe is the World Health Organization study, over 15% of older adults are victims of some form of mistreatment. Pandemic highlighted a lot of the problems that older adults need to deal with. And there are, as I have said all along, significant problems, and they're going to get worse. So we anticipate that by 2060, people with dementia will increase by 2/3. Dementia care in the United States is in general inadequate. It's fine for some people, but for a lot of people it's not. The emphasis has been on improving screening and improving engagement with people as they are diagnosed with dementia, providing much more support for family caregivers, encouraging people to engage in healthy activities, which appear to be, at this point, the only thing that really makes a difference in whether you develop dementia or not. Medications, to some extent, can be useful, and everybody needs better training. Behavioral health conditions going to increase by 10 million over the next 4 decades. Anxiety, 1.9 million. Depression increased by 70% from 3.2 million to 5.4 million. Psychotic disorders, number of people will also increase very substantially. And when it comes to the treatment for mental disorders, it is in general not adequate in the United States. I'll summarize quickly. Most people who get mental health treatment now get it from primary care physicians rather than from mental health professionals. If they get it from primary care physicians, it is minimally adequate, not good, minimally adequate, only at most 15% of the time. Better if they're treated by mental health professionals, where it's slightly over 50% of the time. These are terrible indictments of the quality of care that is available for people in general in our society, but particularly for older adults. The numbers of people who misuse alcohol, medications, illegal substances will grow just in the next few years by 25%, 60% by 2060. So as you can see, we're anticipating very substantial growth of these problems. The costs, it's very expensive, $355 billion in 2021 for the treatment of dementia, growing 1.1 trillion. The treatment of mental and substance use disorder costs about $250 billion a year, so that will multiply. We rely on family caregivers to provide 80% of the care that are provided for older adults with disabilities. That's an estimated value of $470 billion a year, and that's going to grow, and the family burden is going to grow. As I've said, it is possible to age well. And that brings me in 3 minutes to an action agenda, which I will just tick off very rapidly, and then we'll open up for questions and comments. This agenda has 14 items on it. Most important is helping people to live where they want to live, someplace usually in the community. That's often called aging in place. I think that's a misnomer because a lot of people like to move when they get older. They'd rather go to Florida, or they'd rather move to a senior community. So not everybody wants to stay at home, but nobody, loosely speaking, wants to end up in a nursing home. We need to increase service capacity. We need to increase access. We need to increase quality of care. We need to modify services for aging people with severe and persistent mental illness. This is very important, to include care related to chronic physical illness and to provide age-appropriate activities. The mental health service system is very focused on the needs of younger people, working age people. Needs to change considerably. Long-term care services need to be improved, integration. The workforce is a huge problem at this point, and the paraprofessional part of the workforce is becoming an increasing problem as immigration concerns are impeding using immigrants in the way we have as a society to provide care. Support for family caregivers, I mentioned earlier. the need to focus on equity, and then public professional education. Research, there's an imbalance, in my view, in research, much too focused on biomedical research and too little on psychosocial and epidemiological research. Funding, we not only need more, it needs to be redesigned so it works, and we need to improve the data that are available, particularly the epidemiological data, and to have information about where and how services are provided, whether they work, and to know more about how much we're spending and what we're spending it on so that we can do real database spending. Some resources I'll flash too quickly on the screen, or I can leave that there for a while. 2 o'clock, you got 10 minutes left. Can we open up?
All right, fantastic. Great presentation. Great presentation. Thank you so much. I have learned so much. I am actually in the position now why I have become the power of attorney for my dad, who has now been diagnosed with Alzheimer's. So all of this is very new to me, and I really appreciate your presentation.
Well, if I can be helpful at any point, Monique, let me know.
Yes.
It's very tough.
Oh, boy, am I finding that out. I am. So we have a few questions here. And before I get to the questions, there were a few people in the chat who would like to have the slides. But instead of me giving you everybody's email, would it be better for you to give everybody your email so that they can email you individually and they can get that?
Absolutely.
Okay. So if you can just tell everybody your email address and then they can write it down.
And I'd also value hearing from people what they thought of the presentation. As I said at the beginning, this is the first time I've done this particular presentation with this set of slides. It's very rapid, and I would love to know whether people found it useful to run through so much material very rapidly, or they would have preferred a different approach.
I don't see them making comments on that. I think they're still writing down your information. But for me, that was a lot of information, and I appreciate it. And going through rapidly, but the point was that you touched on everything, so you didn't like leave anything out. So if they get the slides, it'll still be, they can get what they did not get. That's my opinion.
Good. So, but you know, if you're going to write to me and ask for the slides, just give an opinion as well.
Okay. Now I'm looking at your email. It says MBFRIEDAMAN.
Oh God. I'm glad you looked. Does that look better?
Let's see. It hasn't come through yet. Yes. Yes. I just thought maybe you're using a middle name or something. I don't know, but
no. I'm just a quiet.
That's okay. That's okay. That's why we're here to help out. All right. So we have a question from Ed McSherry.
There's another address for me too. I hope I got that one right.
Okay, that's mf395@columbia.edu. Okay. All right. So there's one question. There's several questions, but the one I'm looking at right now, it says, do you have any more information on decision-making capacity?
Do I have any more information on decision? Yes, I have some more information, but I'm not an expert on this. I think it's a very important question to raise. One of the issues that definitely comes up, and Monique, you're probably dealing with it now, and that is, at what point does a person with a disability, and it's not just age now, but a person with a disability, a mental disability, at what point do they lose decision-making capacity? I think that there was general agreement, I hope, that sometimes they lose decision-making capacity in some areas and not in others.
Mm-hmm.
And the question here is how much autonomy do we want to try to preserve for older adults? And there are different points of view about that, as you can imagine. We have a problem with our legal system that it doesn't do much by way of partial loss of autonomy. And again, this is not quite accurate, but it's pretty much, all or nothing. And my own view on this, and I dealt with this with my mother, was to involve her in decision making in any way that I could. Even when she became demented, she would have moments of lucidity, and I would try to engage her then. But this is a very difficult personal area. I don't know if that helps. Again, I'm not an expert on this one.
Right. I agree with that. That's what I find the challenge is, what do I say he can do and what is it that I can clearly see he cannot. Yeah. But I try to give him the autonomy to do it without making him feel bad that he really quite missed the mark, on that. And so I'm finding that difficult too. And I asked that question, when do I step in and when do I allow him to continue to have his freedom? So
and I don't know to what extent you can talk about that with him.
With him, yes, I do. For right now, I can. The question is what happens when I'm not able to get that from him?
Have you been appointed his healthcare proxy?
Yes.
You have power of attorney?
Yes.
All right. So one of the things that should be said in the context of this question is there's paperwork that has to be done. So I forgot to say that. There's paperwork that has to be done when you're dealing with a person with a disability who, hopefully before they're disabled, I've done the paperwork, and I've got a healthcare proxy. Somebody's got a power of attorney. I mean, you need to have these things in place.
Right.
And then it's highly personal.
Exactly. But I thank you very much for answering that. You did get a comment from Susan Stewart. She said, I love getting all of this information. Thank you.
You're welcome.
There is a question that says, are there other countries that you think might be doing a better job at hitting those 14 key points?
Maybe. I'm not an expert about what's going on in other countries, but I tend to think that there are countries that have better developed social welfare programs than the United States does. Also want to say that getting good mental health care in other countries is not easy. So that there are countries like Canada, which has a healthcare system that I much admire, but to get mental health care in Canada, not easy. But I don't know, England has a national health service that has built-in mental health care. I don't know if what the quality of that is. So here I am saying in too many words, I don't know the answer to that question.
Well, thank you very much for giving us an answer. Here's another question. It says, do you know if there is a link between bipolar in a family and frontal temporal lobe dementia? I have bipolar and my sister has frontal temporal lobe dementia. Does that make sense?
Yes. Okay. No, I don't know the answer.
Okay.
In general, there is a relationship between severe mental illnesses and the development of dementia, but I don't know anything about whether it's different for I'm stumbling over the words, frontal temporal lobe dementia and Alzheimer's, for example. Um, I would suggest Google.
All right, so
Google
we're
recovery.
almost, thank you so much. We're almost out of time, so I'm gonna ask this one last question. It says, are there any resources you recommend that explain the natural progression and what to expect with aging? I don't understand why we're not taught this in school.
Uh, are there resources? Yes. Are they readily available? No. The lack of education about aging is, I think, appalling. So I teach in a social work school, and most social work students, unfortunately, are not interested in aging. But there's not a hell of a lot that's provided in the School of Social Work about this. In medical schools, there's almost, I'm getting rhetorical now, a little hyperbolic, but there's almost nothing. And there certainly is very limited public information that gives a realistic view of aging. So there tends to be either an anti-ageist view, which says, oh, it's not so bad. And in fact, it could be good. And if you only ate right and exercised and had a positive attitude, man, aging would be just great. And then there's the other view. And now that, as I said, I'm almost 80, that's more my view. Hey, there are things that go wrong in aging that are really tough to deal with. But there's a whole spectrum of what aging can be like, even for people with dementia. And one of the things that I'm very distressed about is that the public image of dementia is almost only of the negative aspects of dementia. And the fact of the matter is that dementia is something that emerges over a period of time, years. And in the early stages of dementia, there are people who write books. And in the early stages of dementia, most people have a life. It's not at all like reaching the point where you don't recognize your children anymore and where you need help with pretty much everything to be able to survive. I've recently seen 2 presentations by groups of people with dementia who have become self-advocates and formed self-advocacy groups. One is a group of retired physicians who have dementia, and they talk about their experiences. And there's another group where the presentation had one person with frontal lobe, one person with Alzheimer's, go through the list of different types of dementia, each talking about what their days were like. They were lucid. They were clear. They were able to, and we don't get enough of understanding that. And one final point that we approach, and I think we have to, we approach the aging and from the standpoint of what help older adults need. We have to do that. We should do that. And we should offer more help, and we should be doing a better job of it. But we also need to understand that older adults can provide help.
Right. I appreciate that. That was a great answer.
But I'm still doing something.
Yes, you are. We really appreciate what you're doing. Thank you so much for everything that you have given and all of your answers. Fantastic. So we're oh yes, absolutely. I enjoyed this. I asked to moderate this for a reason because I was going to attend this class either way. So thank you very much. So thank you for this great presentation. We would like to, well, we already opened up everything. So if you have any questions that we did not answer, you can put that in. Let me see. If you did not have time to answer questions today, please send your questions and the name of the session you attended to connection@namimd.com.